This is about pericardial diseases. So we're going to start with a few questions. I'm going to show you here. So, now, absent pericardium is not compatible with normal life. Yes or no? I want to hear from you. Yeah, is my sound clear?
Yes, clear.
Okay. So absent pericardium is not compatible with normal lifespan. What do you think about it? Guess.
مساء الخير دكتور حاتم.
يا هلا وسهلا.
I think it is compatible with life because in patients with constrictive pericarditis, one of the treatment is to remove the pericardium.
Very good. Very good. Okay. So I will keep the answer. I agree with you, of course, but let's find out. Second question. A patient has cancer with metastasis to the heart. Which of the following is true? The mass will most likely be an intracavitary mass, i.e. it seeds into the endocardium, or the mass has predilection to the pericardium. The mass will be complicated by transitive precardial effusion. The mass are most likely from a melanoma. So, what do you think? Any guess?
The myth most likely from melanoma. D.
Most likely from melanoma. Okay. So I will move on and we will find out all the answers during the course of the presentation. Again, we will come to them again. A 35-year-old male has a stabbing chest pain, which increases on lying flat and mitigated by sitting and bending forward. There is antecedent flu-like symptoms. Which of the following is true? Elevated troponin indicates acute heart syndrome. ECG will show T-wave inversion. Echo will show live precardial effusion. He will need colchicine for 3 months. So, what do you think here?
He will need colchicine for 3 months.
Okay.
D.
Yes. The chest X-ray showed hiatus hernia, artifact, precardial calcification, precardial cyst, raised hemidiaphragm.
Pericardial cyst. D.
Precardial cyst. Okay.
Yes.
This is an ECG of a patient with precardial effusion. The ECG shows complex to complex voltage variation, which indicates / means pulsus alternans, pulsus paradoxus, large precardial effusion, tamponade, or what? If number D is what? Pulsus deficit.
Pulsus alternans.
It is pulsus alternans, huh?
Yes.
Okay.
No, it's a large pericardial effusion.
Large precardial effusion. Okay, good. Good. Now, a 45-year-old gentleman presented with the following clinical and echo signs. See the images. We're going to show you the images. Yes. These are the images. This is a clinical sign. During inspiration, there is a change in RA pressure in the JVP, increases during inspiration, And this is the echo showing septal movement, which is like this. So what's the next course of action? Send for surgery, order cardiac CT, start the patient on a short course of steroid, or follow up in 6 months.
Send for surgery.
Send for surgery. Okay. Good. Okay, great. So the last question probably is this. This is a patient has been admitted for a week for viral pneumonia and is recovering now with stable hemodynamics and no symptoms apart from fatigability. He is due for discharge next morning. What is the best course of action here? Precardiosynthesis for diagnostic purposes, or close clinical supervision, therapeutic pericardiocentesis, or go with the discharge plan? He is recovering from viral pneumonia, and they found out he had this finding in echo. So shall we do pericardiocentesis for
Therapeutic pericardiocentesis.
therapeutic pericardiocentesis? Okay, great. A 54-year-old male, no past history of note, currently asymptomatic. He did this chest X-ray as part of employment checkup. His physical exam is unremarkable. What is the next step?
Cardiac CT.
Okay, reassurance, echo, cardiac CT, or follow-up in 6 months.
Cardiac CT because the X-ray showing pericardial calcification.
Because of precardial calcification. Okay. Now, okay, so if we come to the pericardium, anatomically the pericardium has 2 layers, fibrous and serous. The fibrous is the tough pericardium, the outermost layer overlying the heart and attached to the sternum anteriorly and diaphragm posteriorly. So there is sternocardiac ligament and cardiophrenic ligament to anchor the heart in the thoracic cage and prevent excessive mobility. Now, the serous pericardium is composed of 2 layers, and that's what we usually know. The parietal pericardium and the visceral pericardium, and there is a potentially space between the two, which accommodates around 20-50 cc of serous fluid, which we can see by echo. Okay. Now, what is the function of the pericardium? It limits the displacement. So the heart is anchored in position. So expectedly, if we don't have pericardium, the heart is going to move excessively. It limits the dilatation of the chamber dilatation. Okay. It reduces the friction between the heart and the nearby structure, and it is barrier to infection. But we have to remember that though these functions look kind of essential, but none is. Patient can live normal lifespan with congenital absence of the pericardium. Like Dr. Nihal said, if a patient is having constrictive pericarditis, we strip out the pericardium. So if it's essential for life, probably would have done something different, but it's not essential for life. Okay. So it is not essential for life. It might have a function that we can do away with, and patients of absent pericardium leads normal lifespan. Now, this is the normal pericardium, and as you appreciate here, it's thin, glistening, okay, and encasing the heart. This is the parietal pericardium, and the visceral pericardium is adherent to the heart. Okay. Now compare this with this pericardium which lost the glistening texture. Now it is rough with fibrous strand. This is because of pericarditis. Okay, this is pericarditis, and again, this is a case of pericarditis. And as you could appreciate here, the precardial layer are rough, and the visceral layer is rough. This is the parietal, and this is the visceral, and there is a precardial fluid. So that's why we get friction rub, because rubbing of the two inflamed layers, the parietal and visceral precardium. Okay. Now here is a pericardial calcification. So the pericardium here is thick and calcified. And if you compare this with this, there is no much calcium here, but there is thickening and fibrosis of excessive fibrosis of the pericardium. So we have constriction either because of thickening of the pericardium or thickening and calcification. So we can have pericardial thickening with or without calcification. But in the vast majority of constriction, we have clinically, they will show thick pericardium. Okay, and by thick pericardium, we mean anything more than 2 millimeters. Okay, 2 millimeters is considered thick. Now, can a patient have or has a constriction physiology with a normal thickness of pericardium? Can he or she?
Yes.
Yes. Okay. In Mayo Clinic, actually, they have reported a series of cases of constrictive pericarditis, and the percentage of those who were having constrictive pericarditis without thick pericardium were around 15–18%. Okay, 15–18. So thick pericardium is not going to exclude constrictive pericarditis. Okay, but in the majority of cases, you are going to elicit or demonstrate thick pericardium or thick pericardium with calcification, like this case here. Now, when we come to the Mets, the heart is not a favorite seat for Mets, but sometimes Mets come from common malignancies, okay? And common malignancies and breast and lung cancer. So the majority of the Mets we see in the heart comes from the breast cancer and the bronchial cancer. Now, if we compare primary cardiac malignancy against metastatic cardiac malignancy, which one is more common? Which one is more common? The primary malignant cardiac tumor or metastatic cardiac tumor?
The metastatic.
Sorry?
Metastatic.
Exactly. Metastatic is much more common than primary cardiac malignancy. Okay. Now, we have the heart is anatomically divided into the pericardium, the myocardium, and the endocardium. Now, in terms of the frequency of which of these layers accommodates metastasis, it is the pericardium, followed by the myocardium, and last, the endocardium. So, mostly, the Mets goes and seed in the pericardium, but sometimes they can invade the muscle, and rarely they can be seen in the endocardium as intracavitary mass. Okay, good. Now, melanoma, because some of you has chosen melanoma, melanoma is not a common malignancy. Yani if we take Mets in the heart, if we take a series of 100 patients with Mets on the heart, we will find that above 90% or so are coming from common malignancies like colonic malignancy, breast, and bronchial. But what is special about the melanoma is that once we have melanoma, it has a preferential and predilection to seed in the heart before any other organ. Okay? But because it's not common as the other malignancies, so it's not a common Mets in the heart we encounter in our professional life. We don't see them a lot. Okay? Now we come to pericarditis. And here are the common causes of pericarditis. Idiopathic, in which no cause is certain. Infection, which could be viral, could be tuberculosis, fungal, could be infection, bacterial as well. Uremia, acute myocardial infarction, neoplasm, post-cardiac injury syndrome after cardiothoracic surgery, and systemic autoimmune and connective tissue disease, and after mediastinal irradiation. Now, after acute myocardial infarction, we can have pericarditis, acute or delayed. Can anybody explain to me what it is? Acute and delayed pericarditis?
Acute within 72 hours from the MI. Delayed pericarditis, it takes weeks, 3 weeks.
Okay, good. So in terms of, in acute, we are talking about few days. In delayed, we are talking about weeks and months after the myocardial infarction. Now, the mechanism is also different. The acute pericarditis complicating acute myocardial infarction is due to direct irritation of the pericardium. So you have a myocardial injury, you have anterior wall myocardial infarction, let's say, you have necrosis in the anterior wall, that might spread or invade the pericardium, inflammation, and stuff like that. So it's direct irritation of the pericardium overlying the myocardial injury. Now, the delayed mechanism is different. It's thought to be autoimmune. Okay, so it's antibody-mediated reaction invading the pericardium. Not only the pericardium, it can invade all serous surfaces. Patient might have pleurisy and pleural effusion as well. Okay, he can have pericarditis and pericardial effusion. Okay, so all of these things. He might also come with fever, constitutional symptoms, and these kind of stuff. Okay, this is the delayed type. Compare the delayed with post-cardiac injury syndrome, which we call it postcardiotomy syndrome. Postcardiotomy syndrome. What is it? What is this postcardiotomy syndrome? This is seen actually, I would say, frequently. It's not uncommon at all. I have seen so many patients coming back after cardiac surgery, weeks and months after their surgeries with symptoms, and then we see their chest X-ray, there is pleural effusion and there is precardial effusion. The echo is showing light, moderate precardial effusions and all of that. This is postcardiotomy syndrome. It behaves mechanistically just like the delayed type of pericarditis after myocardial infarction, and it is also thought to be autoimmune reaction. Okay, induced by the injury, by the iatrogenic injury of the surgery itself. Okay, this is called postcardiotomy syndrome, and this is called Dressler syndrome, both of which share the same mechanism or underpinned by the same mechanism. Good. Now, when we come here to the differentiation in terms of clinical and ECG data between myocardial ischemia, pericarditis, and pulmonary embolism, most importantly, the chest pain characteristic of pericarditis is quite peculiar. So it is sharp, stabbing, and worsens with breathing, with inspiration, and with lying supine, and improves with sitting and leaning forward. Okay. Fortunately, the vast majority of patients with pericarditis, you could elicit this history in them. So it's not like controversial diagnosis clinically. So mostly you are going to encounter these symptoms in the majority of patients of pericarditis. They are going to describe this characteristic chest pain. It's not like myocardial ischemia, because myocardial ischemia, especially angina, can present in different subjective feeling, pressure, squeezing, burning, sometimes radiation to the throat, back, and sometimes just sweating, dizziness, different manifestation. But the pericarditis is quite characteristic. Pulmonary embolism is again the same, sharp and static. Okay. Now, duration of ischemia, as we know, it's minute to hours, but for pericarditis, hours to days, as well as in pulmonary embolism, it's hour to days. Now, friction rub is absent here, unless pericarditis is present, unless myocardial infarction few days after has led to pericardial irritation, then you might elicit pericardial rub. But pericarditis, you are going to elicit pericardial rub in 85% of patients. Pericardial rub here, or pleural friction rub, is present only in 3% of patients of pulmonary embolism. Now, as to ECG, we are going to discuss that further in further slides. Now, can somebody describe this ECG for me? This one here. This is
sinus disc with wide concave elevation.
Concave ST segment elevation, good.
And there is a reciprocal ST depression in the AVR. And there is a ST elevation in the AVR with wide spread مش ST PR depression, PR elevation in the AVR.
Exactly.
Wide spread PR depression in the other leads.
Good. So Dr. Suhair has actually described all of the features of pericarditis which are present in this ECG. The concave segment elevation in all leads, and PR depression or sagging, except in AVR. AVR is showing exactly the opposite. So instead of ST segment elevation, there is ST segment depression, and instead of PR depression, you get PR elevation. So AVR lead stands out in this crowd. The rest are showing ST segment elevation and PR depression. Now, compare this one with this ECG. What do you think about this ECG?
ST elevation in the inferior lead.
Okay.
Okay.
This is again pericarditis, but it's not as clear as this one, because you are not going to encounter typical ECG all the time. So sometimes ECG is going to be challenging and not so full-blown like this one. And there are so many cases of pericarditis you might only sort out by imaging, okay? Or you confirm the diagnosis by imaging, either echo, or sometimes you even go for MRI and you demonstrate the hyper-enhancement of the inflamed pericardium. So don't think that ECG is always typical, okay? Mostly it's typical, but sometimes the ST segment elevation and the PR sagging are more of subtle. And that's why, because you know your patient might come in any stage, because the ECG is evolving, okay, over different stages, which I'm going to discuss probably in this slide. This one, you see here, we have stage 1, in which you get this PR depression and ST segment elevation, concave. Then is stage 2, in which the ST segment elevation starts to descend to the baseline. Stage 3, T-wave inversion, and stage 4, normalized. So probably you might get your patient here. It's not as typical as here, okay? And sometimes the ECG might look like this one here, which is so alarming. and probably you might not have the courage to just dismiss acute coronary syndrome or acute myocardial infarction in this ECG. You will think twice before you diagnose pericarditis in this patient, right? Because it looks so much like extensive anterior wall myocardial infarction and stuff like that. Somebody might say, no, this is myocardial infarction with inferior involvement. Why not? But again, you could appreciate the PR, depression, and the elevation here. And it's always about integrative analysis of clinical data on one side, plus ECG data, and sometimes imaging data. Okay, so if you are in doubt, okay, don't just dismiss serious diagnosis. Okay, you might need to go for imaging or even MRI. Now, what are we gonna do when we diagnose pericarditis? But before that, how can we diagnose pericarditis? We have 4 features: the characteristic chest pain, which we have described, the Pericardial Effusion rub, the ECG changes we have described, new or worsening pericardial effusion. And how can I get this information? From echo. So we have 4 features, 2 of which are clinical. One is ECG and one is echo. That means what? For all patients of pericarditis, you are going to take history, you are going to examine them, you are going to review their ECG thoroughly and carefully, and you probably need to order an echo. So 2 out of 4 is the diagnosis of pericarditis. So if a patient is having characteristic chest pain, even in the absence of friction rub and pericardial effusion and characteristic ECG, but you have found that he had new or worsening pericardial effusion, this is 2 out of 4, which is okay. Okay. Now, if a patient, khalas, you finish with the diagnosis, then you go for additional features to help in the management. So after the diagnosis, I'm gonna find out some features that help in the management decision. These features are, if there is myopericarditis, and how can I tell about that? Is by checking troponin. So you check troponin for all patients. If the troponin is elevated, this is not only pericarditis, but this is myopericarditis. Myopericarditis, meaning the pericardium is inflamed, but it has invaded part of the muscle. That's why there is a spillage of troponin in the blood. Okay, so this is myopericarditis. Now, if I ask you what is the difference between myopericarditis and perimyocarditis, what's the difference?
Myopericarditis is the patient present with typical feature of pericarditis, then troponin is positive. But the vice versa in the other is the patient present with acute coronary syndrome, then develop pericardial effusion, directly syndrome. I think so.
You are so close, but myopericarditis meaning you have the first inciting problem is pericarditis, complicated by myocardial involvement. Now, if you have perimyocarditis, that means the initial problem is myocarditis, complicated by precardial inflammation. Okay? So which one comes first and which one led to which one? Myopericarditis is pericarditis leading to myocarditis. Myopericarditis is myocarditis leading to pericarditis. The difference is important because the level of troponin is different. In myopericarditis tends to be, a flat trend and just modest elevation. But in perimyocarditis, it might be high because it's basically inflammation of the muscle. Okay, the muscle is inflamed. So that's a big difference between the two. Now, always try to elicit the high-risk features, which are fever, leukocytosis, large precardial effusion, cardiac tamponade, history of trauma, patient on oral anticoagulation, or elevated troponin, or relapsing pericarditis. Now, why should we look for these high-risk features? Because we need to decide if this patient has to go for admission or outpatient treatment. Okay, so any of these high-risk features, hospital admission, at least for observation, because if a patient is having elevated troponin, that means there is myocardial involvement. You will not have the courage to discharge this patient. It's unsafe because he might go into arrhythmia. Okay, if a patient is having large precardial effusion, even if he is stable clinically and by echo, no features of compression, it might progress over few days or sometimes few hours. So you have to keep this patient in hospital. Now, acute trauma, because trauma is kind of bloody and it is progressive. So what you are seeing now is not reflective of what's going to happen in the near future. So you keep these patients. Patient on oral anticoagulation, they might bleed in their pericardium and end up having massive hemorrhagic pericardial effusion. Okay, so leukocytosis and fever indicate the intensity of the inflammation. That's why you should keep patient of intense inflammation in hospital. If you rule out all of these high-risk features, it is safe to treat the patient as outpatient. Okay, so what's the treatment? What's the treatment? What is the treatment?
Non-steroidal aspirin.
Okay, so non-steroidal
Or
plus
non-aspirin.
yes, or others
Plus
plus
colchicine.
colchicine. See here, no prednisolone, non-steroid. So non-steroidal for 2 weeks and colchicine for 3 months. Now the protocol we are following here, we are giving colchicine for all patients. I see some people might just start with non-steroidal, and if there is no response or there is relapse, they give colchicine. But I think it is better to give aspirin and colchicine the same time. So first line therapy is aspirin and colchicine. Aspirin, or I mean non-steroidal anti-inflammatory for 2 weeks and colchicine for 3 months. Prednisone might be considered in relapsing pericarditis, but otherwise it's not, because it might retard the healing process and it might increase the incidence of relapse. That's why it's not given unless a patient is having frequent relapses of pericarditis. Sometimes the patient might have relapsing pericarditis and we give prednisolone or immunosuppressive therapy, and sometimes some few patients might fail to respond to this regimen and might end up needing pericardiectomy for relapsing pericarditis. Okay. Now, for precardial effusion, usually, how do we analyze precardial effusion? We analyze precardial effusion in terms of onset. Is it acute, subacute, or chronic? Size, is it mild, moderate, or large? Distribution, is it localized or circumferential? Quality, what is it composed of? Can we know this in echo? No, most likely we cannot probe into the quality precisely, but we might have hints about whether it is, hemorrhagic or not hemorrhagic. When there is fibrous strands, that means there is high protein content or inflammatory process, something like that. But definitely we cannot know exactly about the what is it composed of, because this needs chemical analysis. Okay, etiology, what's the cause of this precardial effusion, and importantly, the hemodynamic effect, how much this effusion is affecting the heart. Okay. Now, how can I differentiate or distinguish between precardial effusion and pleural effusion? Because it's not uncommon to have a patient who is having both precardial effusion and pleural effusion. So your landmark is the descending aorta, what comes above it and what comes below it. Above it is precardial effusion and below it is the pleural effusion. And also the other feature, which is the pleural effusion ends abruptly here at this junction, while the precardial effusion can go all the way to just below the descending aorta. Okay, so this is another differential feature. A third differential feature in the pleural fluid, if you focus your attention well enough, you might see something in the middle, right? Like this one here. What is this? What is this?
Lung tissue.
Lung, exactly. Okay, so you might see the lung. So if you see a effusion and the lung in that effusion, this is pleural effusion. Why should I bother? Is it so difficult to distinguish between the two to the extent that I will be looking for the lung tissue and stuff like that? Yes, yes, of course. Look at this. Look here. Imagine that you don't have this collapsed lung and you just have this fluid. It is very hard to tell which is which. Is it pleural or precardial? But once you have seen the lung here, the lung tissue in the fluid, that means all of this is pleural effusion, not precardial effusion. So look for the lung. Okay, it's important. Now, this is fibrous strands traversing the pleural, the precardial effusion. Sometimes we call it septation of the precardial effusion. What's the significance of this? First, it tells us that this is most likely exudate or hemorrhage or inflammatory pleural effusion or chronic long-standing. Once it forms these fibrous strands, that means something different. And the other thing is that it makes the process of pericardiocentesis a bit challenging, because if you go by your needle here and you might aspirate, it is kind of pocketing. The effusion is now pocketed into different segments, so it might not all come in your needle. So you need some time to insinuate your needle to crack and tear the septa to get the drainage on. Okay, so this is fibrous strands or septation of the precardial effusion. Now, what is this and what is this?
The first one is fatty layer. The second is pericardial effusion.
This one is?
The first is the fatty pericardium, epicardium, the fat.
This is fat. Okay, and this one is?
The effusion.
Okay, great. Thank you so much. So this is fat and this is effusion. And I brought this slide because it's not uncommon that we sometimes get confused between fat and precardial effusion. Okay, so the fat tends to be a less hypodense, more of isodense, like in this is hypodense or hypoechoic. This is isoechoic. And you might demonstrate some granularity somewhere here. Okay. But the fluid is more of homogeneous hypoechoic. But if this is a hematoma, nobody can say, no, it's not a hematoma, because the hematoma also has the same echogenicity like the fat. Okay, so sometimes to differentiate between these entities isn't easy, okay, between the effusion, the fat, and the hematoma, okay? So it needs a bit of practice. Now, this is really important. The most scared complication of precardial effusion is tamponade. When do we get tamponade? That's the question. And what are the predictor of tamponade? Is it the size of the effusion or the rate of accumulation of the effusion? Both are important. If I take you to this graph here, as the volume increases, the pressure increases. And this pressure takes us to tamponade physiology. But the rate of this pressure increase is different between the rapid effusion and slow effusion. Because if you have a slowly accumulating fluid, the precardium will have a chance to stretch out to accommodate with this increasing pressure before the volume of the precardial effusion exceeds the limit of precardial stretch, after which the pressure starts to rise. Compare this with the rapid effusion. The rapid effusion, no chance for precardial stretch. The precardium is not going to adapt. So the pressure rises significantly and abruptly. So the fast accumulating fluid are more hazardous than slowly accumulating fluid. Now, the other thing is that as the precardial fluid increases, as it increases here, we get increased intracranial pressure, leading to increased RV and LV pressure. Now, what's the behavior of the cardiac output? See, the cardiac output is steady, declines just slightly until a point after which everything turns ugly. Patient sleeps in cardiogenic shock. So this is the problem of cardiac output. The cardiac output does not follow a gradual descent. It abruptly goes down. And that tells us something, that the onset of tamponade shock is so unpredictable. It is unpredictable, okay? The patient might be so compensated an hour ago, and now he is in cardiogenic shock. Because cardiogenic shock means the precardial effusion has now affected the cardiac output. All these pressure rises, okay, are premonitory signs, but what translates into clinical shock is the cardiac output. Okay. Now, this is a chest X-ray, and we have done a session about chest X-ray, but I just want you to tell me how are you gonna measure the cardiothoracic ratio. The cardiothoracic ratio, to tell us whether we have large heart, is to divide the heart by the spine into two, left and right, and you take the largest left and the largest right, and you sum them together. This is the cardiac diameter with the largest thoracic diameter. And then you divide the two to get the cardiothoracic ratio. So doing this one like this obliquely is not right. Is not right. You have to do it this way, okay? This is the standard way of assessing the cardiothoracic ratio, okay? Remember, the spine is your landmark, the largest from the spine on the left and the largest from the spine on the right. The largest thoracic cavity, okay? Or the largest thoracic diameter. Now, what is this? This is the so-called water bottle sign. If you see, tell me now, if you see this heart in a patient in ER, how confident are you this is pericardial effusion? How confident are you?
Just suspicious.
Exactly. So don't take these romantic water bottle flask shape, goose on fence signs as, you know, this is confident signs of tamponade. They are, or live Precardial Effusion. They are not. They are not. Yani, yes, you might, and it is legitimate, and it is it's right to suspect large Precardial Effusion, but remember, you might not find one, okay, because it might just be due to the orientation or any other chamber dilatation, like the atrium and ventricle might give similar morphology. Okay, so the response to this chest X-ray is definitely do echo, not pericardiocentesis. You have to do echo to make sure what you are seeing here is a fluid, not something else. Okay, good. Now, this one here is the precardial effusion. You see, this is the precardial effusion in CT. And what is this dark density immediately overlying the heart? What is this dark density? Can anybody tell me?
Fat.
Thank you so much. This is epicardial fat. So this is epicardial fat, and this is precardial effusion. There is also what here? Pleural effusion. Okay. This is a contrast CT. Can we see precardial effusion in non-contrast CT? Yes. Again, this is precardial effusion, and this is pleural effusion, and this is fat. Okay. Now, anybody, what do you see in this chest?
Pericardial calcification.
Precardial calcification. Any other thoughts?
Coronary calcification.
Yeah.
I think coronary calcification.
Pulmonary calcification.
Coronary.
Coronary calcification. Okay. Okay. Good trial.
Pneumo Pericardium.
Pneumo Pericardium.
Yes, exactly. Thank you so much. This is a Pneumo Pericardium. You see here, this is the draining catheter. This is the draining catheter in the precardial space. This one. Okay. And this one, which you think it is precardial calcification or coronary calcification, is the parietal pericardium, which is thick. It is very thick. This is a patient of metastatic precardial tumor. I mean, colonic cancer metastasizing to the pericardium. That's why the pericardium is now thick here and here, and complicated by malignant hemorrhagic precardial effusion. They drained it, but unfortunately, they have introduced air in the pericardiocentesis process, and this is the pneumo pericardium. So pneumo pericardium usually complicates. I mean, it's not usual that pericardiocentesis leads to pneumothorax, but pneumo pericardium. But pneumo pericardium mostly is iatrogenic. But sometimes it's due to trauma. And if a patient is having a trauma, okay, yeah, it is conceivable that the trauma might suck air into the pericardium. Or rarely, if there is a fistula between the bronchus or esophagus with the pericardium, you might get air there. And theoretically speaking, I'm not acquainted about any case of such case of bacterial infection like Clostridium with air generating bacteria that can lead to pneumo pericardium. But theoretically, it's a valid cause as well. But mostly it is iatrogenic. So this is pneumo pericardium. Now, the pulsus alternans, because every time I discuss pulsus alternans and paradoxus and pulsus electrical alternans, I find a bit of confusion. Now, pulsus alternans is a clinical sign in which the pulse alternate between strong and weak, beat to beat. So if you are checking carotid or radial, you are going to appreciate high and low volume, high, low, high, low, high, low. And this is a sign of what? Severe LV dysfunction. Okay? Severe heart failure LV dysfunction. Okay? Pulsus paradoxus is something different. Pulsus paradoxus, you see that the changes in the arterial pressure is respirophasic, not beat to beat. Is respirophasic. So this one and this one and this one are similar. The other three are similar, then it comes again. During inspiration, the pulse goes weak. During expiration, it recovers. This is pulsus paradoxus, which is a clinical sign of tamponade. So now we have discussed the pulsus alternans, the pulsus paradoxus. Now what about, this is also pulsus paradoxus. You see here during inspiration, it goes low, during expiration, it goes high, then inspiration, then expiration, inspiration. So it is respirophasic changes of the pulse volume or pulse pressure, okay? Compare that with pulsus alternans, which is beat to beat variation in the strength of the pulse due to severe LV dysfunction. Now, what is electrical alternance? This is electrical alternance. You see, ECG, complex to complex variation in the amplitude. So low, normal, low, normal, low, normal, low, normal, and so on and so forth. And that is due to a large precardial effusion leading to a swinging movement in the heart. So the heart is swinging or waving like this. So it comes close to the thoracic cavity on which your leads are overlying, and it goes away. It comes close and away. That's why the leads on the thorax here are capturing high amplitude, low amplitude, high amplitude, low amplitude. So this is what? This is electrical alternance. Electrical alternance is an ECG sign and not a clinical sign. Yani if you put your hand in the pulse, you are not going to appreciate anything. It is not a clinical sign. Now, this pulsus alternans is a clinical sign and not an ECG sign. Okay? So please assure me that you understand this before we go further. So did you understand this well?
Yes, yes, very clear.
Yes, it's clear.
Now, this is a low voltage ECG. What is the definition of low voltage? Low voltage meaning less than 5 millimeter in the limb leads and less than 10 in the pericardial leads. This is the definition of low voltage. It's not necessarily both. You say that less than 5 in the limb leads and or less than 10 in the pericardial leads. Now, what are the causes of low voltage? It is basically due to the heart being covered, or your leads and the heart are now separated by precardial effusion, pleural effusion, or fat, obesity, air, COPD, pneumothorax, subcutaneous emphysema, infiltrative connective tissue diseases like myxedema, infiltrative myocardial diseases like amyloid, sarcoidosis, hemochromatosis, constrictive pericarditis, and scleroderma. But it also can be a sign of loss of viable myocardium in massive myocardium infarction and end-stage dilated cardiomyopathy. So these are all causes of low voltage. So low voltage is not only precardial effusion, okay? Is not only precardial effusion. It can be pleural effusion, can be obesity, can be COPD, pneumothorax, myxedema, and so on. Amyloid, you know that amyloid is one of the causes of low voltage, right? But here, when we talk about infiltrative cardiac diseases, amyloidosis, sarcoidosis, hemochromatosis, Fabry's, and all of that, not always leading to low voltage, not always. Amyloidosis can and cannot lead to low voltage. Mostly, it leads to low voltage ECG. Now, Fabry's leads to high voltage. And why is that? Infiltrative disorder sometimes leads to low voltage, sometimes it leads to high voltage. The speculation about this is that it depends on where this infiltrate is deposited. Is it deposited in the interstitium or into the myofibril? If it's deposited in the myofibril are going to be stout and they will be electrically more potent. But if it's deposited in the interstitium, the myofibril are going to be separated, okay? And the space, the interstitial space is going to widen at the expense of the myofibril space, and that will lead to lower electrical potency. Okay, that's why in Fabry's, because the deposit is inside the myofibril, is different than amyloid, where the deposit is in the interstitial space. Good. But before you jump to the analysis of low voltage, remember always to look at the calibration signal on the right or the left of the ECG. Are we using the right calibration? The calibration signal is 10 millimeter, equivalent to 1 millivolt. So you should always see here a signal like this is spanning two large squares to standardize your ECG. Now I can play with the calibration the way I like. I can increase the calibration or I can decrease it. Now this is half standard where 5 ml equal to 1 millivolt. See, this is the same patient. Look at the QRS complex voltage. It decreases a lot just by changing the calibration. So before you think of low voltage and the causes of low voltage, make sure that the normally standard calibration signal is set right. Okay. Now, what is this here? Can somebody tell me what is this? Parasternal long axis. Okay.
So I think pericardial fat.
There is pericardial effusion, right? Okay, good. How large is this pericardial effusion?
Small pericardial effusion.
Sorry?
Small.
It is small, exactly. So how we measure the size of the pericardial effusion? We freeze at diastolic frame, not systolic. So we choose diastolic frame, and then we measure this one. If it is less than 1, it is small. 1 to 2 is moderate. More than 2 is large. Okay?
Yes.
Get that?
Yes.
Good. And you always have to look at all the images, all the orientation, to see how much of pericardial effusion and whether this pericardial effusion is circumferential or loculated. Not only that, even for circumferential pericardial effusion, which cover all the heart, sometimes the fluid has larger pool in some places rather than others. So you might see that there is larger fluid anteriorly, or there is larger fluid posteriorly, or there is larger fluid at the apex. So you have to define whether your fluid is circumferential or loculated, and if it is circumferential, where is the largest pocket of fluid? Why it's important to localize the largest pocket of fluid? For pericardiocentesis, we want to direct the operator to where he should go. Yani if I find that it is here, this one, I will go subcostal. If it is here, I'm going to go apical. If it's here, I'm going to go parasternal. Parasternal, I mean apical. If it's here, I will also go apical. If it's in the anterior, like here, I might go parasternal. Okay, so this is important. Now, we said that part of the evaluation for precardial effusion is the size, and we have spoken about that. Now, the hemodynamic effect. What are you seeing here? The right atrium is compressed. The right atrium is compressed due to precardial effusion. What is the significance of this?
Tamponade. Tamponade. Indicating
Tamponade.
It indicates tamponade. طيب بس أنا I just want to do small correction here. RA compression or RA inversion is not a sign of tamponade. It is sensitive but not specific of tamponade. Yani you can see it with innocent bystanding fluid. Okay. Lakin you can increase the specificity of this sign if you quantify it. And by quantification, I mean, look here at this M mode of the right atrium. This is the M mode. What is here is the compression. And now it goes back. So this is the duration of the compression. So if this duration of the compression of the right atrium is more than 1/3 of RR interval, this is specific of tamponade. So the point here, RA inversion is not specific unless it is quantified and it occupies more than 1/3 of RR interval. Then it is specific. Okay? Good. This is different than RA compression. RA compression is specific regardless of the quantity. So here, and the RA, you see the RA compressed in diastole. See, now it's compressed. It is compressed. Okay. Now look at the RA compression here. The RA compression here is sensitive but not specific, but it can be specific if we time it to the cardiac cycle and we see that it occupies equals to or more than 1/3 of RR interval. But here, if you see this one, it is important. This is important sign and specific sign of tamponade. اللي هي RA RV free wall collapse. RV free wall collapse. Okay. And just a moment while you are seeing this one. Can anybody tell me what's
This is hemorrhage among the external ICU. Cut through the left through the RV, showing diastolic collapse of the right ventricle.
شكله دكتور حاتم الصوت.
Sorry, sorry, I'm so sorry. Okay, I was muting myself. You said RV collapse. Yeah, I can see the RV collapse by the emoji here. Okay. What else? What else? Look at inspiratory face. Inspiratory face, you see the RV cavity is bigger than inspiratory face. And the opposite in the LV cavity. LV cavity is larger in expiration and is smaller during inspiration.
Increase interventricular dependence.
Exactly. This is because of interventricular interdependence. But I wish from now on, we don't call it interventricular interdependence because this is physiological. We call it enhanced interventricular interdependence or exaggerated interventricular interdependence because it happens physiologically. But during tamponade and constriction, it becomes enhanced. The septum moves vigorously left and right, respirophasically. So during inspiration, it moves left. And during expiration, it moves right. That's why the cavity of LVRV changes accordingly. Okay? Good?
Yes.
Okay. Now, IVC is so important. IVC is so important to check in any patient with large precardial effusion, moderate precardial effusion, or as part of your evaluation. Why it's important?
Because it reflects in the right atrial pressure.
Okay, because it reflects the right atrial pressure, right? If I don't see plethoric IVC, so the IVC is small and collapsible, what does that mean?
Secluding
exactly. It rules out tamponade. It almost rules out. So specific, you know, that's why it's important. And the most one that correspond to the clinical manifestation of tamponade. Okay, that's why it's important. The other thing that we should always do with precardial effusion is to interrogate the mitral and tricuspid with a spirometer. And we see the changes. Now, this is the mitral flow. See the mitral flow during expiration, it is high. During inspiration, it's low. Do you understand why? Do you understand why? Right? You understand why? Now, in tricuspid, during expiration, during inspiration is here, during expiration is here. Inspiration, expiration, inspiration, expiration. So during inspiration, the velocity increases. During expiration, it's low. The opposite in the transmitral. Okay. Because a little bit of this is physiological, so we have to go quantitatively here. Tamponade means how much of these respirophasic changes are present. It's not about they present or not. It's not binary, yes or no. It is quantity, how much. But usually we take the mitral as more than 25% variation and more than 40% variation here to be significant of tamponade. More than 25% here, more than 40% here. Okay? Okay?
Yes.
Good.
Yes.
Now, what is this here? This is the LVOT, the Lvot tracing. So, anybody can explain this signal or describe what's she's seeing here?
During expiration, it increases.
During inspiration, it
Decrease.
You see, during inspiration, it's here. I'm going to show you with the pointer. Just a moment. See, during inspiration, it is here. Okay. During expiration, it is. During expiration is here. This one, sorry, this one is expiration. Yeah, this one expiration. This is expiration. Sorry, I'm lost. Sorry. You see here when the spirometer goes up, this is what? Inspiration. When it goes down, this is expiration. Inspiration, expiration. Agree? So this one here is what? Expiration. So this part is expiration. This part is inspiration. So compare the signal here to the signal here. During inspiration, it is low. During expiration, it is high. This is in the LVOT. What does that mean? What clinical sign corresponds to this?
Pulsus paradoxus.
Exactly. This is pulsus paradoxus by echo. You know, because we are just checking the LVOT flow, what's going to be? The blood pressure soon.
Yes.
Exactly. Okay. So we can check pulsus paradoxus by echo, but now we are going to check the LVOT velocity in inspiration and expiration. And if it's anything more than 10% changes, it is significant. Okay. Good. Now, if you have seen a large precardial effusion, like this effusion, we have seen this effusion and this effusion, okay? But the patient is stable, blood pressure, heart rate, complaints of nothing. What are you going to do? Pericardial synthesis, or watchful waiting, or do something else? What are you going to do?
We are going to investigate diagnostic pericardial synthesis and send for.
Again, sorry.
We carry on investigation to look for the cause.
يعني you will not, Dr. Suhair, you are not going to do pericardial synthesis.
ممكن diagnostic.
Diagnostic. Okay. And I assure you, diagnostic pericardiosynthesis is mostly unyielding. Usually it takes you nowhere. So the search of etiology should be based on clinical evaluation and, you know, other analysis. But the pericardiosynthesis, I mean, the diagnostic yield of pericardial fluid isn't high. Biopsy may be, yes, better. And even biopsy, you might miss where the inflammation is. And sometimes the involvement of the pericardium is patchy. So you might not strike the right place. I'm not okay with diagnostic pericardiosynthesis, but therapeutic pericardiosynthesis, are you going to do it, or you are going to wait for the patient to be clinically, I mean, tachycardic and hypotensive and in shock?
If I found plethoric IVC, I will do pericardiosynthesis.
Okay.
Or RV collapse. This if I found was.
Okay. So this is about whether you will be proactive or reactive. Proactive means you do something before the complication arises, or you wait for the complication to arise and then you act. In precardial effusion, the complication is what? Is shock. So being reactive to shock is gonna make you fall way below optimal therapy, because not only that, it's gonna jeopardize the patient's safety really a lot. Now imagine that you have a patient for whom you are called and he is in tamponade and cardiogenic shock. how much time you need to take this patient to an area to do the procedure and arrange the kit and do this and that, and it's a hell of time sometimes. Okay, and the patient is cardiogenic shock. But if you take the patient early on, you might have time to arrange and everything. So acting proactive is probably better than waiting until the patient become clinically in shock. Lakin, having said that, it's a matter of integrative analysis, because sometimes the patient might have a risk of the procedure itself. He has high INR, bleeding tendencies and stuff like that. So the procedure, if it's taken earlier, is probably riskier than wait and see, and the effusion might regress in size and patient might be fine. So it's not like, you know, decisive that we should always go for pericarditis. But it is better to act proactively than reactive. That's the slogan. Okay? But each case has its own requisites and its own, you know, decision. Now, this is how we do it. You can do it blind, and I don't advise you. You can do it fluoro guidance, and I don't advise you. You can do it ECG guidance, and nobody is doing that anymore. And if you can, do it echo guided. Echo guided is safe and easy. So these are the windows. You can go subcostal, you can go apical, you can go parastatal. And you have to sheath your probe to be sterile. And after you scrub the patient area, who is gonna do it? The interventionist or the echocardiographer or who? One of them. But the one holding the needle should be the same one holding the probe.
Correct.
It's one single operator. Should be single operator. Huh? فأنت you hold the probe and define where the largest pocket is to decide about your site of piercing. This is one thing. The other thing is also you want to know the distance from the skin. How much from the skin here to give estimation about how deep should you go. Because the problem sometimes is that you might go as deep as to be in the cavity, and you might suck blood from the cavity, and the patient will just go in further shock, even worse. But you assume that you are draining a bloody precardial effusion. So you have to make sure that you are not sucking blood from the cavity. You are here. So you have to decide how much distance. And then if you go by the probe guidance, you are going to see your needle coming from above. You see this needle? It is coming from above. So now the needle is descending slowly and gradually in the precardial space. So you are seeing yourself. And if you are in doubt, through this needle, inject saline, and you are see that saline is opacifying the fluid, not the chamber. So you are in the precardial space. So now you can. Okay. So the echo will tell you about the largest pocket. So where you should go by your needle. It tells you about the distance from the skin and how deep you go with your needle. And it tells you about the needle coming in front of your eyes. And of course, after you are done, you can do echo evaluation and see how much you have drained and how much the heart recovered. Okay. Good. So what is this emote? It is a hard one. You see, this is the septum, okay? This one is the septum. You see, this is the septum. It goes up and down. This is the RV here. The RV is here. The LV is here. So what we are seeing is during inspiration, which is here, the RV cavity widens at the expense of the LV cavity. And during expiration, the opposite is true. So this is enhanced interventricular interdependence physiology or pathology, enhanced interventricular interdependence, which is the mechanism of tamponade and the mechanism of what else? Constriction also. Okay. So are you following with me?
Yes.
Yes.
Assure me that you are not bored already.
No, we are following.
Sure.
Follow.
I
Yes,
know
yes.
cardiac disease is a bit tough. That's why. Okay. Now, any smart guess here? Smart guess. This is M modes of the aortic valve. What are we seeing?
Decreasing the opening of the aortic valve.
Sorry?
Decreasing the opening of the
I
aortic
see.
valve.
Decreasing the opening of the aortic valve. We missed it here and here.
Then it starts to
Maybe,
open
yes.
again.
And then it opens again. What is this?
This is pulsus paradoxus.
This is what? Thank you so much, Rabah. Thank you.
Paradoxus.
Thank you. I never thought somebody is going to guess it right. This is pulsus paradoxus by M mode. So now we have seen pulsus paradoxus by echo. We have seen it clinically by hemodynamics and now by the M mode as well. Okay. So you see, this is, by the way, extreme form of pulsus paradoxus, where the flow almost ceased in inspiration to the extent that the aortic valve loses its opening or it becomes just weakly opening like this. And then it comes again. So this is inspiratory phase. This part is inspiratory phase. And this one is expiratory phase. And so on and so forth. Now what is this? What is this? RV.
The systolic collapse of the RV.
RV collapse. I have shown you RV collapse in 2D, which is here. This one is the RV collapse in 2D. Now this is RV collapse in M mode, which is even better to appreciate. How do I know this is diastolic collapse? Because see, the aortic valve is opening in systole and it's closing in diastole. So this is a diastolic event. This is diastolic. So you can time it either to the aortic valve or mitral valve to know which part of the cardiac cycle you are seeing the collapse in. Because the collapse might be here. Now, what is this collapse? I see collapse here. This is normal physiological systolic collapse. Because during systole, there is inward movement of the free wall. But this is the pathological one, which is the diastolic collapse. So you have to time it with the cardiac cycle, okay?
Okay.
Now, another smart guess. What is this? It has nothing to do with precardial diseases. I brought it here just to show you the beauty of M mode sometime. And like the presentation from which I took this slide, M mode is still alive. M mode is still alive. So what is this? You see the posterior wall? This is the posterior wall. You see, this is diastole. And then this is systole. But before systole, there is a hump. So systole does not go like this and this. It goes like this, this, and this. So what is this?
This is flattering of the anterior mitral leaflet.
The anterior, the mitral leaflet is probably here. Maybe it's this one. No, this is the aortic valve, most likely, or what? Isn't it? I don't know what it is. This is mitral, most likely. But this is the posterior wall. This is the posterior wall. You see here, diastole, systole start with a hump and then it peaks.
Systolic anterior motion of the mitral valve.
Sorry?
Fluttering, I think fluttering of the anterior mitral valve leaflet.
But the problem I'm referring to is in the posterior wall. This is the LV and this is the posterior wall. Follow the posterior wall, you are going to find that this is systole. Sorry, this is diastole, and systole start with a hump and then it peaks. Usually it is diastole and systole. Diastole and systole. But now we are seeing diastole, a little bit of systole, and a big systole. What is this? So double systole. This is pre-excitation WPW. In WPW, you will have a short PR interval, and you have the delta wave. The delta wave is pre-excitation, meaning the LV, you are going to see the complex like this. You are going to see the complex start like this, and it goes like this, right? So through the accessory pathway, the LV is excited, so it start contraction. But when the normal complex comes through the normal, the normal electricity comes through the normal route, it makes the systole the usual one. So there is fusion between pre-excitation systole and normal systole. They fuse together, and we sometimes can appreciate that by the MR. Okay?
Okay.
A bit tough, you know. Now what is this? Pericardial cyst. Okay? Usually it sits in the right cardiophrenic angle. This one here. This angle, sorry. This angle is the right costophrenic. And this one is the left costophrenic. So the pericardial cyst lies typically in the right cardiophrenic angle. And here is a calcified cyst. Again, the same location, which is typical. And here we can see it in CT, okay, compressing a little bit on the right atria. So what shall we do about precardial cyst? Most likely you are gonna stumble upon them. So mostly they are incidental finding because mostly they are asymptomatic. Like here by echo, I'm gonna see them beside the right atrium. This is a cyst, precardial cyst, and this is a large one, large and compressing on the right atrium. So if it is compressive or associated with symptoms, you have to do surgical excision. Otherwise, no therapy is indicated. Okay?
Yes.
Good. This is an excised precardial cyst, and this is how it looks. Now, this is precardial calcification, like you see here. And when we take the lateral chest X-ray, it shows us the calcification even better. Even better. So if you want to look for precardial calcification, order a lateral chest X-ray. Lateral chest X-ray is more informative as to the precardial calcification than AP and PA orientation. Okay? This is one important point. Second, if you have precardial calcification, CT is the best imaging modality to depict the amount and the distribution of calcium. Cardiac CT. You see how we are seeing the calcium eggshell calcification. And what is this here? What is this? This is precardial calcification invading the myocardium. And this is important, by the way, to see not only the extent and distribution and how thick the precardial calcification is, but also it's important to know how much it invades the myocardium. لأنه that is going to make the surgery really, really difficult and risky. Okay? So this is why we need to have cardiac CT. Okay? Chest X-ray alone is not going to tell you about the extent and how deep it goes, but cardiac CT will. Now, echo is so lousy in the precardial depiction, so you don't see a lot by echo. That's why cardiac CT is important here. Now, this is a case of precardial constriction, and you see it's actually an extreme form of precardial constriction to the extent that it has led to chamber distortion. You see this geometrical distortion of the LV, it is compressed basally on both chambers, kind of wasted, and there is atrial dilatation. We don't see much of the precardium in echo, but we are seeing the influence of the precardial constriction. Okay. Now, this is the lateral annulus. You see the mitral valve here. I'm going to draw it here to you. This is the mitral valve. This is the lateral annulus. This is the medial annulus. So this one here is the lateral annulus. This one is the medial annulus. If I check the velocity here and here, physiologically, the velocity along the lateral annulus is faster than the medial annulus. Okay?
Yes.
Why?
Yes.
Why? Because the lateral annulus is more free than the medial annulus. The lateral annulus, the medial annulus is connected to the cardiac skeleton, so it moves slower than the lateral annulus. لكن لما يكون عندك precardial calcification, it's going to hold this lateral annulus and it slows it down. بالتالي الفيلوسيتي هنا هتكون أقل من هنا. الميديال annulus will become faster than the lateral annulus. And this is called annulus what?
Reversus.
What?
Reversus.
Annulus reversus or inversus. Annulus reversus. Sometimes we can call it annulus paradoxus. Some people think that annulus paradoxus is different time, but I think for me, annulus paradoxus, annulus inversus, annulus reversus, the same terminology. You just have to understand the concept behind that. Now look at this lateral annulus. The velocity is here, the lateral annulus. It is 9.9. Look at the medial annulus. The velocity is 10.3. So it is faster. So the medial annulus is faster than the lateral annulus. This is one of the specific signs of constriction. Now we come to the hepatic venous Doppler as well and do interrogation. And what we are seeing is during inspiration, see the inspiration is this one and expiration is this one. So what we are seeing here during inspiration, sorry?
Increased reversal flow.
Increased reversal of increased flow reversal during expiration. You see expiration, the flow, compare this one with this one. So this is the reversed expiratory flow and this is the reversed inspiratory flow. So it's more in expiration than inspiration. Why is that? Look here at the right atrium. The blood is coming through the IVC here. Okay. Let's say that we are in an inspiratory phase during inspiration. During inspiration, the septum goes this way, the cavity enlarges, the blood moves easier, and this the flow will be like this. The reversal, the one that goes back, is small. But during expiration, the septum moves this way, it narrows the cavity, it increases the pressure, so there is much of backflow. So the flow reversal will be like this. The backflow. The backflow is basically due to how much the forward flow is meeting resistance. The more resistance it meets in the inflow, the more it goes back. So during inspiration, it meets less resistance. So less amount of blood goes back. During expiration, it meets more resistance. That's why more flow goes back. That's why there is more reversal of flow during expiration. So this is important sign of constriction. Okay. Now, what are we seeing here? It's the septal bounds. You see the septal bounds? Try to focus on the septum. You see, it is bouncing. See, 1, 2, 3, now bounce. 1, 2, 3, bounce.
Yes.
So the septal bounce is the respirophasic movement of the septum. So it goes left during inspiration and it goes right during expiration. So it goes left during inspiration and it goes right during expiration. Okay. And here also is the septal bounce. Okay. So now we have discussed all the signs of constriction. The precardial thickening and calcification, the geometrical distortion and dilated atria, the annulus inversus, the increased expiratory flow reversal, and the septal bounce. And this is the cosmal sign, which is an important clinical sign of constriction and also of tamponade, in which you see during inspiration. Normally, during inspiration, the venous pressure drops because the right atrium is relaxing better and accommodating more inflow. But if a patient has constriction or tamponade, during inspiration, the flow increases, the venous pressure increases, or it fails to drop. So during inspiration, you see the RA pressure increases and it decreases during expiration. So this is cosmal sign. What are we gonna do for constriction? Are we gonna go ahead with surgery or wait and do something different? If you have made the diagnosis confidently by echo, sometime you fail to do, to confirm the diagnosis by echo. In such case, you might need to go for cardiac cath, but usually the need for cardiac cath is really of limited role because in the majority of cases, you could establish the diagnosis confidently by echo. Now, if the patient is having clinical features and echo features and you finalize the diagnosis, then we come to the treatment. If it's chronic constrictive pericarditis, we go for surgery. But if you suspect it is transient constrictive pericarditis, effusive constrictive pericarditis, you might consider a short-term management with non-steroidal, steroidal, and other treatment before you consider pericardiotomy or precardial stripping. How can you tell? Is it a transient here or is it chronic constrictive? يعني الآن أنا if I have seen a patient with precardial calcification, eggshell calcification, and I have elicited the physiology of constriction by echo, this is chronic constrictive pericarditis. لكن مرات إذا لقيت إنه no much of calcification, والclinical features are not that full blown, echo features are not so full blown, there is a small precardial effusion, and there is some kind of a material that might be inflammatory material in the precardial space, I might wait. Okay, لكن it depends. يعني أي case you have to individualize the treatment. Now, surgical stripping, is it easy surgery or difficult surgery? Easy or difficult?
It is difficult, I guess, because
Difficult surgery.
Sorry? the mortality is as high as 6. Actually, the mortality, and I found it ranges from 6% to 40%. Can you imagine that? Yani the least mortality in the best hand is 6%, which is great, which is big deal actually, but it can reach up to 40. That means it's a difficult surgery with lots of complication and risk. So you have to make sure that you are taking the right patient in the right time. This is important. It's not a matter of diagnosing constriction. It's about when to decide about surgery. Okay. You have disputes, and echo does not establish the diagnosis, you can go for invasive hemodynamics. And here is the constriction pericarditis hemodynamics in cath lab. When the LV pressure goes high, the RV pressure goes low. When the LV pressure goes low, the RV pressure goes high. What is this? Enhanced interventricular interdependence. So during inspiration, like we said, the RV pressure goes high because more blood is coming to it. But at the expense of that, the LV pressure is going to be low. And during expiration, more blood is coming to the LV than RV. That's why LV goes high and RV goes low. So this is called, what is it called? It is called discordance. It is discordance. LV-RV discordance, because they are discordant. The higher, the lower, the lower, the higher. Discordance. Now, in restrictive cardiomyopathy, as the LV goes high, this goes high. As this goes low, this goes low. This is called concordance. Concordance. In restriction, concordance. In constriction, discordance. Okay? Good?
Yes.
Now, I think, I don't know, I have few slides to come, but I don't want to bore you any further. So if you want me to continue, I'm okay. If you want me to stop here, I'm okay.
You can continue. Continue.
Now, this is important difference between precardial constriction and constrictive, restrictive cardiomyopathy. And we used to ask about, we still ask about the difference between the two a lot in exam. The most important thing I want to draw your attention to is here. Pro-PMP. Pro-PMP tends to be higher in restrictive than constrictive. Why?
Because the restrictive is muscle disease.
Yes, thank you so much. And because constriction is?
Pericardial disease.
Exactly. And not only that, لأنه الconstriction هو بيعمل إيش؟ هي الPro-PMP is a marker of what? Stretch marker. It is a stretch marker. The constriction actually limits the stretch of the chamber. Like in for restriction, no. In restriction, apparently the walls might look small, but they are under stretch. Like in constriction, the calcified thick pericardium is restricting the stretch. عشان كده بتكون شوية أقل البروبين. Now, pulmonary artery systolic pressure is higher in restrictive than constrictive. Why is that?
The constriction is a disease of biventricle,
Okay.
and the restriction is most likely confined to the LV.
And the diastolic dysfunction is more likely to be advanced, more advanced in restriction than in constriction. And restriction will also be associated with overt or covert systolic dysfunction. So there are so many reasons to elevate the LVEDP in restriction more than in constriction. And consequently, the pulmonary artery systolic pressure is higher here than here. Okay? So these are important differences. Now, last thing is here, if you look at this heart in the cardiac CT, you will notice that the heart has shifted more leftward and posteriorly than the usual posture of the heart. This is because of congenital absence of the precardium. This is called precardial agenesis. So we mentioned in the first slide that the function of the precardium is to anchor the heart in a special posture in the thoracic cavity. So when we lose the attachment, then the heart swings leftward and posterior. Okay? And when the heart moves posteriorly and leftward, the transition zone changes. So usually we get the transition at V3, okay, in which we get QRS complex equidistance between the negative and positive, and then it starts to be positive. Then this is the precordial progression. But if it moves leftward so much, so we get the transition a bit late at C4 and C5, or V4 and V5. Okay? This is because of leftward. And this is an echo of a patient of pericardial agenesis. And that, as you could appreciate, that the heart is excessively moving and the chamber are a bit dilated. Because we said the function of the precardium is to anchor the heart, prevent excessive mobility and chamber enlargement or chamber dilatation. That's why we have here a heart which is moving excessively with chamber dilatation. لكن المشكلة ما كبيرة مع الcongenital absence of the precardium. قد تكون المشكلة أكبر لو عندنا partial absence of the precardium. Partial. يعني الآن لما يكون أنت عندك الهارت كده, I have the whole heart, ما فيه precardium. It's not like I have a precardium all here and here, and I don't have it here. ليه؟ لأنه معناته المكان ده it can herniate outside. Like here, this is partial absence, okay, leading to herniation of the underlying segment of the muscle. Okay? لأنه الpressure overlying these segments is lower. That's why it herniates. Partial absence can sometimes lead to herniation. And this herniation can be dramatic sometimes. And this is a patient who came in with ischemic symptoms, and they did him coronary angio, and this is what they found. Look at the course of the LAD. The LAD goes this way, and then it dips like that. Then we lose track of it. Then it comes back again here. So this is kink because of herniation of the apex. There was congenital absence of the precardium from the apex, and it herniates. So if I draw the heart, it will be like this. herniation like this. That's why it distorts the course of the LAD, leads to kinking and ischemia. You see, this is partial absence and herniation of the chamber. So I will take you back to the question. Absent pericardium is not compatible with normal life, yes or no?
No.
No, it is compatible with normal lifespan. Yes, I'm going to see a heart that is excessively moving, that has gone leftward and posteriorly, that has chamber dilatation, but no big deal. A patient has cancer with mets to the heart. Which of the following is true? The mets will most likely be an intracavitary? No. The mets has predilection to the precardium?
Yes.
The mets will be complicated by transitive precardial effusion?
No,
No, usually it's hemorrhagic. The mets are most likely from melanoma? No, most likely from common malignancies. Okay?
Yes.
So the mets has predilection to the precardium, then the myocardium, and least the endocardium.
Yes.
A 35-year-old male has a stabbing chest pain which increases on lying flat, mitigated by sitting and bending forward. And there is flu-like symptoms. Which of the following is true? Elevated troponin indicates acute coronary syndrome? No. Elevated troponin indicates myopericarditis. ECG will show ST segment T-wave inversion. No, we have described the
No.
ECG.
ST.
Yes. Echo will show large precardial effusion. Not necessarily.
No. Not.
Not necessarily. Yani if a patient is having pericarditis and you do echo, you might find no precardial effusion, a small precardial effusion, large precardial effusion, moderate precardial effusion. Okay? The patient needs colchicine for 3 months.
Yes.
Yes.
Non-steroidal for 2 weeks. Yes, that's the right answer. This chest X-ray shows this is the typical location and morphology and appearance of, thank you, precardial cyst. Now this is
Precardial Cyst.
yes, we said this is electrical alternance, not pulsus alternance, not pulsus paradoxus, not tamponade, not pulsus deficit. It is due to a large precardial effusion and a swinging heart. A 45-year-old gentleman presented with the following clinical and echo features. I think we have this one here, which is cosmal sign here, and this one is respirophasic septal changes in the position of the septum, in which during inspiration, so this is constriction. So send for surgery or order cardiac CT, start the patient on short course of steroid or follow up in 6 months. Of course, if you send your patient for surgery, it will be a bit premature because I need to know this, the precardium, how it looks in terms of calcification and thickening. Okay.
Yes.
But this is so important. Okay. Lakin, most likely, the step after cardiac surgery, after cardiac CT is cardiac surgery. Yes.
Yes.
Okay. Now, what are we going to do for this patient? Has been admitted for a week for viral pneumonia and is recovering now with stable hemodynamics, no symptoms. He is due for discharge next morning. So are we going to do pericardiocentesis for diagnostic purposes, or close clinical supervision, or therapeutic pericardiocentesis, or go with the discharge plan?
Therapeutic pericardiocentesis.
Exactly, because we need to act proactively here. This one is right. Okay, and I'm taking it as right. But if somebody choose this one, it is also right. Close clinical supervision. I'm not going to discharge this patient, and I'm not going to pierce, I'm not going to stick a needle in the pericardium yet, but I'm going to closely follow him up. This is also right. There is no right and wrong here, but as we have discussed, you have to keep a vigilant eyes on this patient, okay? And if you want to act proactively right now, this is better. But it's not wrong that you are not going to do something here now because the patient is stable and you are going to follow him closely in hospital it is not wrong. Last, 44 male, no past history, currently asymptomatic. He did this chest X-ray as part of employment checkup. His physical is unremarkable, يعني ما عنده constriction, clinical features of constriction ولا كده. What is the next step? Reassurance, echo, cardiac CT, follow-up chest X-ray after 6 months.
Cardiac CT.
هنا السيكونس كالآتي. After you do chest X-ray or and clinical evaluation, ولقيت مثلا في precardial calcification. A sequence goes for echo then cardiac. فهنا الايكو is important. لانه انا قبل ما اعمل الكاردياك سي تي خلاص it's in preparation for surgery. لكن قبلها انا I need to know هل البريكارديال calcification دي is imposing physiology ولا لا. This is by echo. So I need to know his echo before I go for cardiac CT.
Okay.
Echo is the immediate next step. لأنه لو طلع عنده features of constriction by echo, even in the absence of clinical features, I need to act now. Okay? يعني not necessarily the patient is having full-blown picture of constriction clinically. If he is showing constriction physiology by echo, خلاص, I will go for cardiac CT to see how to map out the calcification and do cardiac CT. So thank you. I think that's the last. Thank you so much.